Hello, I'm Susan Patricelli Regan, and I am delighted to have as my guest today uh, is Dr. Thomas Balcezak, and he is the Chief Clinical Officer for Yale New Haven Health. I do want to mention that as the Chief Physician Executive for the health system, he is charged with enhancing clinical care delivery by leading work that improves quality, safety, cost, patient and family experience, and clinician engagement. Welcome, Doctor. It's a delight to have you as a guest today on Connecticut Valley Views.
Thank you very much.
Now, obviously, I just kind of gave an overview of your responsibilities, but you might just tell us how you've gotten into this role and a little bit of background.
Sure. So I'm a Connecticut native. I grew up in East Granby, went to medical school in UConn. And there I met my wife, and we did our residencies together in New Haven at Yale. Along the way, my wife decided she wanted to do a different residency. So we had a couple of kids by then. And so we found ourselves thinking about what our long-term plans were going to be. So I retooled my career. Instead of following the traditional path of doing a fellowship, thinking about pulmonary critical care at the time, I decided I would put my efforts into process improvement. It was along the time then, back in the late 90s, when quality improvement, which had touched so many other industries, was really getting its toehold in medicine. And I got interested in how to use some of the new tools that were coming, like the electronic medical record, to try to improve the quality of care. And so my wife and I settled into a very nice sort of arrangement where she did her residency and I went to work for the then chief of staff, who happened to have been my chief of medicine at the time. And, 25 years later, we have developed a whole different set of infrastructures. We've moved from being a single academic hospital in New Haven to an academic health system that spans the 100 miles that is the coastline of the state of Connecticut. And I'm glad to say we have infused a much more clinical focus into the operations and strategy of how our health system delivers care to the communities across our region.
So when you say clinical strategy, just give us an explanation of what you mean by that.
Well, healthcare is changing, and the needs of our population is changing. And one of the things that has been a tremendous change in the last 25 years is how medical advances can get into local communities. There was a time where, in order to get the most cutting edge therapy, you had to go to an academic medical center. Well, our perspective is different. Our perspective is you should have access to those cutting edge therapies at Greenwich Hospital, for example.
I see.
And the way we do that is we create these clinical programs or service lines that are distributed across all of these different communities. Mm-hmm. And there are some things that are only done, for example, in New Haven, like, for example, solid organ transplant. But recently we opened a stroke service at Greenwich Hospital that they can now do neurosurgical clot removal if those clot busting drugs don't work. That would have been unheard of 20 years ago.
Sure. So this is actually a culture that you've been able to make more widespread rather than a central area, which obviously does improve the health opportunities for people because they don't have to travel the distance, and it's a more cooperative effort. Now, with regard to really our major topic here is regard to COVID-19. How has the staff, how have they done stress-wise during these past number of months? It's almost a year now. Have you had to add staff? Have you had to rotate staff? What have been some of the challenges that you've faced?
Well, I think that what I just described in terms of an academic health system is actually really, it really benefited us and benefited the citizens in Connecticut over these last 10 months that we've been in this pandemic, because we've shared our clinical care protocols. And as you remember, it was only a few short days ago that marked the 1-year anniversary of the first case reported out of China. That was on December 12th. So really, we are still learning so much about this disease. First we learned about it. We learned its genetic code on January 12th of 2020. And then we began to really sort through what treatments could and would and didn't work. And we all remember the hope and then dashed hopes of whether or not azithromycin or hydroxychloroquine or convalescent plasma, all of these things that we cycled through. And, we were because of what I described as the system that we've created, is we were very quickly able to pivot when we learned what worked and what didn't work. Yes. And then we were able to apply those care protocols in all of our clinical areas, all of our ICUs. So that made a big difference for us. The other big difference for us was the use of telemedicine. Mm-hmm. So, the most precious resource that we have, arguably, in this pandemic is our ICU beds.
Yes.
And one of the most precious parts of that ICU is our staff. So one of the ways we were able to extend our staff, our physicians, for example, is through the use of telemedicine, where one physician in a setting very much like this would be able to manage multiple patients. We did add staff. It's hard to create new healthcare staff in a short period of time, and they're tired. We had a big surge in the late spring and through April. We got a little bit of a reprieve over the summer. But then in the middle to the end of October, the numbers started creeping up again. Yes. And we'll see where they go, but hopefully they won't go much further than where they are now.
Now, you talked about some of the therapeutics. Were there ones that were more successful than others, or were there certain segments of the population, the elderly, the younger, where some worked and others didn't?
I always try to divide the therapeutics into pharmacologic and non-pharmacologic therapeutics. And the only two drugs that have worked so far are steroids, which we've been using since the beginning, and this drug that Gilead makes called remdesivir, that in my opinion has a relatively modest improvement. And recently, 2 monoclonal antibodies were approved for outpatient therapy. But that's pretty much it for the pharmacologic therapies. Non-pharmacologic therapy in the treatment protocols have made an enormous set of advances. For example, we now know that we can use very high flow oxygen and try to prevent people from needing ventilators. And it's pretty successful. And when you add on to that, putting patients prone, that is on their belly, that actually helps them too. So we've made a lot of progress in how we manage those patients clinically. The drugs really have been, I think, other than steroids, pretty much a bust.
I see. Now, with regard to treating these patients that came in, did you ever at any point were you needing of anything, whether it was ventilators or other equipment that you were not supplied within time, or was there a challenge there as well?
Yeah, we faced a number of challenges. We never actually ran out of anything. But we came pretty close a couple of times with regard to the personal protective equipment that everyone's heard about. So the respirators, gowns, gloves. We actually created a mechanism to reuse and re-sterilize and then reuse the N95 respirators. These are the ones that are made by 3M that look like a cup over your mouth, and they provide a high filtration level. And we created a novel way and then had it approved by OSHA and the CDC to use a hydrogen peroxide vapor system to sterilize them and reuse them. And without that, we probably would have gotten into trouble, but we didn't. It did have a huge impact on the hospital, however, in the health system financially. I mean, normally these respirators cost about $0.25 a piece. In the height of the pandemic in April, our acquisition costs was somewhere around the $6 to $7 range for each one. And so that had a profound impact on our finances this year.
Of course. Now, when you had people coming in, was there confusion with people who've been tested, but now they've got some symptoms? how did you define or how did you identify that it was actually the COVID-19? Because obviously you could have a very heavy duty cold, you could have the flu, maybe even something else. Is that quickly identified when a patient comes in and says, I feel terrible, and the doctor, perhaps their PCP has directed them, they should go to the hospital? How quickly do you define what it is?
Well, we have not seen a whole lot of flu or cold. There is a fair amount of overlap, particularly with flu symptoms to COVID-19 symptoms. We haven't seen a lot of flu this year. Some of it is just seasonality, but a lot of it is because the masking and physical distancing and hand hygiene that everyone has been performing is extremely effective at preventing the spread of flu. So far, touch wood, we've had a very low incidence of flu this year. And so the patients that have been coming in with respiratory symptoms and sometimes GI symptoms, we have treated all patients that have symptoms that are consistent with COVID-19 as what we call persons under investigation, or PUI. And we keep those patients isolated. We swab their nose. We have in our hospitals across our health system a rapid test that can give us a 2-hour turnaround time. And we save those tests for those PUIs so that we can quickly sort out who does and doesn't have the disease, so we can effectively isolate, cohort them, and begin the process of trying to get them better.
All right, let's talk about age groups. I mean, we know the nursing homes were a major problem everywhere in the United States and so forth, but give us a sense of age groups or where it was primarily needed for you to address it as COVID-19 and follow whatever procedures you could do.
Well, we didn't really have a lot of treatment protocol differences based on age.
Okay.
But what we did see was, as you point out, the impact of this disease is very much pronounced among the older age cohorts. There's a local reporter, Dan Haar, who did a really nice job back in July. And he basically characterized, at the time, there was about 4,500 deaths in the state of Connecticut due to COVID-19. And he was able to demonstrate that really close to 90% of those deaths were in age 60 and older patients. And we saw that in our own institution, is the people at most risk of mortality are those that are older, especially those that are older and have other kinds of conditions, diabetes, heart disease, and other conditions that can make them frail and susceptible. And there's really not much more additional that we can do for them other than the supportive care that I've mentioned with pharmacologic and non-pharmacologic therapies. There's no additional therapies that were found to work differently in those age groups or in those cohorts than in other people. It's just that simply this disease is much more devastating for that group.
Yes. All right. So let's just take a case of someone doesn't feel very well. They haven't felt well for, let's just take a median age 50 and on up, and they don't feel very well and they've had a headache. What would be the most critical signs for someone to actually pay attention to the fact perhaps they should go to the hospital? Because a lot of people will just take an aspirin and ibuprofen and say, oh, I've had, I think I'll be fine. And so what would be key things? Is it an upset stomach? Is it a tremendous headache? Are there very specific signs that tell you this is a critical time to make a move?
Sure. So you outlined correctly a lot of the symptoms that patients present with COVID-19. You didn't mention fever or cough. And cough has really been, and shortness of breath has been the most common finding for patients that require hospitalization. And while you can have COVID-19 and simply present with a headache or abdominal pain, the symptom that really gets people in trouble is pulmonary symptoms, coughing and shortness of breath. My recommendation is, if you are a person who regularly gets headaches and it's not that uncommon and you normally take a Tylenol or an aspirin or Advil or something, go ahead and do that. If it persists or somehow seems more unusual, you should call your doctor. The same with GI complaints, stomach upset and the like. If it's frequent or common for you to have that, that's fine. If you find it somewhere out of the ordinary, then you should probably give your physician a call. And more importantly, if you really think that you may have symptoms that are just a little unusual and might be consistent with COVID-19, it's important to wear a mask and stay away from other people, particularly that elderly population we were talking about earlier. But until you get that sorted out, try to isolate yourself, keep yourself away from other people, especially if you have a cough, which is the more common symptom. That would definitely cause you to call your physician and see if you can get tested as an outpatient. But again, until you're tested, you should try to remain isolated. So if it is that you are infected, that you're not spreading it to others.
All right. Well, before we get into the vaccines and vaccinations that you are now currently midstream on, what would say a successful recuperative time be? You come into the hospital, you have some issues, perhaps you don't get to the ventilator point, but what would you say is the time frame that is spent in the hospital before that you get released? You come in, you need some assistance, perhaps you get a therapeutic, whatever. What, 2 weeks in the hospital?
I think it depends on your symptoms. I mean, we've had people that have come in for 2 or 3 days. They've turned around very rapidly and been able to go home. We've had many patients, we've had thousands of patients diagnosed in our testing arena that have never required hospitalization.
Wow.
It's really, it's not that every patient that gets COVID-19 goes to the hospital. It's actually a small percentage. Probably around 10% of people that get COVID-19 need some sort of medical care, perhaps in a hospital. And of that 10% that goes to the hospital, there's a range of length of stay from 2 days onward, unless you go to the ICU. About 10% of that 10% ends up in the ICU, and their length of stay can be measured in many, many days. We've had patients in our hospital for as long as 40 and 50 days in the ICU recovering. And it's not really understood why there's so much variability in how this disease progresses. And while we're talking earlier about how it can impact people it does impact people in later decades much more severely.
Yes.
We had some people in their 30s and 40s that were very sick, on ventilators for many weeks, sometimes needed heart-lung machines to keep them alive. And unfortunately, far too many cases had passed away. So this is not a disease that's solely in the elderly population. Yes. It simply just impacts them more broadly.
And probably they may have other medical conditions and maybe preventative, they've got other medicine they take, and you have to be careful what you're doing with regard to that. And I also think there's a big thing I believe in it, that stress can have a major factor in people's recuperative powers. Just worrying about what do I have, am I going to be okay, can wear down the body.
Absolutely.
It's a major factor. All right, let's talk about, you've started the vaccinations, is that right? Was it the Monday this week?
It was. We received the vaccine. It's been a real whirlwind. It was Tuesday we received the vaccine in the morning, 8:15. Tuesday at 1:00 we gave our first 5, and then Wednesday morning we started our vaccine clinics in all of our hospitals. And on Tuesday, I think we vaccinated about 420 individuals on Tuesday. Today being Thursday is our second full day of vaccination.
All right. And now, so obviously your staff, your frontline staff, your doctors, your nurses, and so forth. The rollout to the rest will be nursing homes, I believe, the elderly, or anyone who may be in prisons where there are large groups of people, and so forth. Which of the vaccines are you currently doing? Is it the Moderna? Is it the Pfizer? Which one are you using?
Well, as of right now, the only vaccine that's approved for use in the United States is the Pfizer vaccine. The process to approve the Moderna vaccine took a big step forward today. The FDA is meeting to consider its emergency use. And if they vote yes on that over the weekend, just like last weekend, the CDC Advisory Committee will meet, and then we may have Moderna approved as early as Sunday or Monday, which is what happened last week with Pfizer. And if that follows the same path, we could have as many as 7,000 doses of the Moderna vaccine, we're told, on Tuesday or Wednesday in our health system.
All right. Now, with regard to utilizing both of them, the media has been stressing the fact that Pfizer requires a very low temperature to maintain it, a proper structure to utilize it, and Moderna does not. Are there any other major differences with regard to you having to handle those two?
Yeah, there are slight differences. The technology that's in the science that's in the Moderna vaccine is quite similar to that of the Pfizer vaccine. And although Moderna doesn't require a freezer quite as cold as the Pfizer freezers that are minus 70 or 80 centigrade, they still are much colder than your normal household freezer. One of the things about the Moderna vaccine that makes it somewhat easier is that it's more stable at a refrigerated temperature. Once you thaw the Pfizer vaccine, it's only stable for 5 days at a refrigerated temperature.
Okay.
The Moderna vaccine, once it's thawed, can be stable for 30 days. So that gives you a little bit more flexibility in its administration.
Yes.
The other difference is really very small, is that Pfizer requires 2 vaccinations 21 days apart, whereas the Moderna vaccine is 2 vaccinations 28 days apart. And that's simply, what they chose to study.
Yes.
Based on their preliminary findings. But that's what we're going to stick to, because as the FDA approves things, they will be approved with parameters, and we will be required to stick to those parameters.
All right. Now, with regard to actually Acting State Public Health Commissioner Deidre Gifford has said that the shots are going to be available to everyone at no cost, even those without health insurance. Is there a financial burden on the hospital with regard to which they use, or one more costly than the other?
Well, neither of them cost anything for the acquisition, as the federal government has spent upwards of 12 to 14 billion dollars on the research and the pre-purchase of all of these vaccines.
There's no pass through to the hospital and no pass through to the patient.
Correct. So the other part of it, though, is that and you heard Governor Cuomo say this in New York, is that there may be an administrative charge, but for folks that don't have insurance, they will not be charged. People who do have insurance, they'll be charged for that administrative charge, but there'll be no out-of-pocket copay, deductible, what have you. I'm trying to lower the barriers for everyone, because in order to protect our public, we need to get to 80% of the individuals and get them vaccinated. So anything that's a barrier, I think we all need to remove.
Yes. Well, what I understand, and again, when you listen to the media, that if we could get 75% of the nation vaccinated, that would have the herd value that we need to perhaps rid ourselves of this problem.
Yeah, this concept of community immunity has been applied to other diseases, and it's between 70 and 80%. So 75 sounds about right. If we can get there, the chance that we can completely stop the spread is very high.
All right, and now going forward, I know it's been, I don't like to bring up the subject, but have there been in any of the segments when they were testing it, any deaths from the vaccine testing?
No, there were deaths among the 40,000 individuals that were studied, but they were equally spread between the placebo group and the vaccine group. And when they looked into them, they had nothing to do with the vaccine. If you study a group of 40,000 individuals for a long enough period of time, inevitably there are going to be some deaths.
Yes. Are there any specific rules or things that you need to be concerned about that you should not get the vaccine? Who would be at risk not to get it? I mean, let's just say a pregnant woman shouldn't get it, or they should get it, or is there any segment of society that needs to be watchful?
There's been no hard stops on any segment of society except for 16 years of age and under. That was a decision made by the CDC's Advisory Committee on Vaccines. In the trial, that's basically the population that it was given to. Okay. With regard to pregnancy, that's come up a lot. Actually, the American College of Obstetrics and Gynecologists, as well as the Society for Maternal Fetal Medicine, have both made recommendations that pregnant women or women who are planning to become pregnant should not be excluded from vaccine eligibility. But it is their personal choice. No one right now is mandating this vaccine. It is a choice. But I think it's important to state again is that, the major societies of the individuals who are experts in the care of pregnant women or women who are about to be pregnant has said women should be given access to this. The same goes for breastfeeding women. I've received a lot of questions about people who have compromised immune systems. People who are getting chemotherapy,
Yes.
people who are on drugs, who are on drugs to care for diseases like lupus or inflammatory bowel disease. Again, none of those are contraindications. In fact, those drugs and those conditions put you at increased risk of complications in COVID-19. So paradoxically, those individuals should absolutely get the vaccine.
Well, it's been a very interesting and informative today for our viewers. I do want to thank Yale New Haven Health and the doctor for all of the time that he has given to us for this show. And I would like to also give the website in order for you to follow up on what is next for the community, for our important state of Connecticut and its citizens. And it would be www.ynhh.org. I also like to remind our viewers to see all of our shows on Connecticut Valley Views at www.ctvalleyviews.com. This is Susan Patricelli-Regan, thanking you for joining us today.
Sylvia Davis Patricelli was an extraordinarily accomplished, internationally recognized portrait painter, whose historical painting collections spanned 2 continents, the United States and Australia. Her first exhibition was opened by First Lady Eleanor Roosevelt at G. Fox & Company, Sentinel Hill Hall in Hartford, Connecticut, and sponsored by Beatrice Fox Auerbach, president of G. Fox, WTIC, and the Wadsworth Atheneum. See Sylvia's 501c3 charity website, which was initiated in 2017 to provide scholarships for high school seniors and secondary educational students pursuing a career in the creative arts. www.sylvia, Davis, art.org. Thank you.